Welcome to this lecture, Infection Control and Nosocomial Infections in the Intensive Care Unit. First, we'll start with some definitions. Healthcare-associated infection, or nosocomial infection, is often abbreviated to HIA. Central line-associated bloodstream infection can be known as CLABSI. However, it's also confusingly known as a catheter-related bloodstream infection, or CLABSI. And VAP stands for ventilator-associated pneumonia. The first person to observe and record the possible link of infections spread between one patient and another was Semmelweis in the 1840s. He saw that the medical students and doctors were performing autopsies and then going and doing obstetric examinations on labouring women and thought this may be the cause of puerperal fever. At the time, he prescribed a lime hand wash and mortality rates decreased. However, at the time that this was prescribed, there wasn't a real recognition of the fact that microbes were being spread. But even now, routine hand washing has become a cornerstone of infection control practices. So why are nosocomial infections so important and why do we need to consider them? Well, nosocomial infections cause increased patient stay, increase the number of resources needed to look after these patients, and they also lead to increased mortality. The commonest sites for nosocomial infections include the urinary tract, surgical wounds, bacteremias related to central lines and even peripheral lines, and also pneumonia. It's estimated that up to 10% of hospital patients will acquire an infection during their hospital stay. And given numbers in the US, they're actually associated with nearly 100,000 deaths per year, so they're very significant. In the intensive care, central line-associated bloodstream infections and ventilator-associated pneumonia are the two commonest causes of nosocomial infections. The reason that intensive care patients are more at risk include the fact that they have multiple indwelling catheters and foreign bodies that allow microbes easy access. These patients also have a decrease in their normal physiological defences, and unfortunately intensive care units often have high rates of infection with multi-drug resistant microbes such as MRSA and VRE. When considering those organisms that are responsible for most hospital-acquired infections, they are usually organisms that are multiple antibiotic resistant or are highly contagious. One of the best known agents of hospital-acquired infection is MRSA or methicillin-resistant Staph aureus. Another resistant form of Staph aureus is known as Visa or vancomycin intermediate Staph aureus. This fortunately is not very common. Another bacteria that is vancomycin resistant is an enterococci, and collectively this is known as VRE. This is fairly common and requires quite specialised cleaning to get rid of it from surfaces in patients' rooms, and does seem to spread fairly readily within hospital inpatients. Clostridium difficile is fortunately not common presently. The difference here with this is that hand washing with soap and water for 30 seconds is required to rid the healthcare worker from carrying Clostridium on their hands. Some less common causes of hospital-acquired infection are the gram-negatives that carry extended spectrum beta-lactamases, or ESBL group, which includes some Klebsiella, some Enterobacter and some Acinetobacter. As it suggests, these bacteria are resistant to penicillins and cephalosporins. We should also think of the viral causes of hospital-acquired infection, which include influenza and RSV, and also potentially HIV and hepatitis B and C. The transmission of hospital-acquired infection can be by direct contact between staff and patients, where they have their hands or devices colonised with bacteria. It can still be through inappropriate sterilised or cleaned equipment, and then uncommonly through respiratory droplets, or very rarely through blood-borne viruses. When we're looking at central line-associated bloodstream infections, it's important to remember that most critically ill patients will require a central venous catheter as part of their initial management and resuscitation. They allow ready access to a large vein, and they also allow the monitoring of the central venous pressure. However, there is the downside that the longer these devices are in, the increased risk there is for infection. It is sometimes difficult to actually diagnose a catheter-related bloodstream infection. Ideally, there should be a positive blood culture that is taken from a peripheral site, not directly through the central venous catheter, as a positive result from a central venous catheter sample may reflect colonisation rather than a true bacteremia. There are a number of well-recognised risk factors for development of CLABSI. These include patient factors and catheter factors. Of the patient factors, perhaps immunosuppression and the use of TPN are common causes, and also burns patients are known to be at high risk of getting CLABSI. When we're looking at catheter factors, we look at things like the duration of time that the catheter has been in place, and the longer the catheter is in place, particularly after 7 to 10 days, the more likely an infection is to be related to it. Also, the number of lumens that the catheter has. An increasing number of lumens is associated with an increasing risk of infection. The site of insertion of the central line, so neck lines are less likely to get infected than lines that are placed in the femoral vein. Also, interestingly, the skill of the person inserting is a risk factor. So, with increasing level of skill, the person inserting is less likely to be infected, and also the type of catheter. And these days it's very common to find antimicrobial impregnated catheters in use, or antibiotic catheters in use. So some simple steps to preventing CLABSI include removal of the central venous catheter when it is no longer required, using strict aseptic technique when placing the central venous catheter or accessing the central venous catheter, having someone skilled in placement of the catheter actually insert the catheter, avoiding placement at the femoral site, and actually changing the infusate sets regularly. For example, things like TPN, which have no preservatives or antimicrobials included in it, the lines need to be changed every 24 hours. Now looking at ventilator-associated pneumonia, or VAP. Typically, this is a pneumonia that develops after 48 hours or more of intubation and ventilation, and it is fairly common in the long-term ventilated patient. The common pathogens responsible for ventilator-associated pneumonia include the gram-positives like Staph aureus, and the gram-negatives, for example, Klebsiella, E. coli, Pseudomonas, and Enterobacter. These bacteria may also be resistant to one or multiple antibiotics. When diagnosing ventilator-associated pneumonia, it is important to use some criteria, particularly if you're looking for potential interventions to decrease the risk, or if you're carrying out any clinical studies. So the diagnosis of ventilator-associated pneumonia relies on the presence of new or progressive infiltrates on chest X-ray or CT chest, plus any new fever, sputum, neutrophilia, or increasing oxygen requirement. In the diagnosis of VAP, one should also obtain a microbial specimen. This is done through sending either a sputum from suctioning of the patient or actually doing a bronchoscopy and getting some washings directly from the bronchial tract. There are a number of measures that can help prevent ventilator-associated pneumonia in the intensive care patient. This includes extubation of the patients when it's appropriate to do so. And there are a number of other methods to try and prevent bacteria in the mouth or gut from spreading into the respiratory tract. This includes nursing the patient in the head-up position, usually done at least 30 degrees with the back of the bed raised, using a cuffed endotracheal tube, and regularly checking that this cuff is inflated adequately, and also using routine mouth care in all intensive care patients, which includes chlorhexidine mouthwash and brushing of patients' teeth where appropriate. In the treatment of ventilator-associated pneumonia, it is important when designing empiric regimens that this is based on local antibiograms. This is obtained from information taken from the previous 6 to 12 months of the most recent ventilator-associated pneumonias, the agent that has caused, and the sensitivities. This is usually done in conjunction with the infectious diseases team and the microbiology laboratory. Once the actual organism that's causing this episode of ventilator-associated pneumonia is known, the antibiotics can be de-escalated and targeted, and usually are only continued for 7 to 10 days. Let's go over some general infection control principles that apply not only to the intensive care, but also to the general hospital or even GP surgery. Firstly, when we're looking at preventing spread of infective agents, the most important thing is to practice good hand hygiene. This means that you need to wash your hands before and after every patient contact, or even after contact with potentially contaminated instruments or dressings. In recent years, hand hygiene has been improved by the availability and ease of alcohol-containing hand disinfectants, which make the availability of hand hygiene at every bed space and every doorway possible, without the need for a hand basin and taps. Another step to prevent spread is good aseptic technique when placing invasive devices such as cannulae or central venous catheters, and also to remove these devices when they're no longer required. Other ways to prevent spread include having adequate staff numbers. This often directly applies to nursing staff. Also, to make sure that staff are vaccinated against common agents that cause hospital-associated pneumonia such as influenza and hepatitis B. To provide adequate disposal methods for dirty equipment such as sharps and blood-stained equipment, and also to provide adequate cleaning of equipment and surfaces. Preventing the development of multi-resistant bacteria is another important step in hospital infection prevention. This can be achieved by appropriate use of antibiotics and also with close liaison with the infectious diseases teams. This is known as antibiotic stewardship and involves the use of narrow spectrum antibiotics once the infective agent is known, shorter durations of appropriate antibiotics, and also gathering information about local infections and antibiotic sensitivities. Another step of prevention is surveillance. This means routinely checking patients for multi-resistant bacterial colonisation. Also changing intravascular access devices after predefined periods. If there's timely communication between the microbiology laboratory and treating clinician, this can also narrow the spectrum of antibiotic use and treat infections more appropriately. And if there seems to be an outbreak, then the use of an infection control team to identify any index cases and also to recommend infection control practices is useful. So the practical points of prevention and what you'll see actually in day-to-day practice include the use of hand antisepsis containers everywhere, often a dedicated stethoscope for each patient, or at least cleaning stethoscopes with alcoholic wipes between patient use, the avoidance of long sleeves and ties and lanyards and minimal hand jewellery, the use of isolation rooms for patients that have colonised or infected with VRE and MRSA in an attempt to decrease the chance of spread to other patients in the intensive care unit, the de-escalation and stop dates for antibiotic to decrease the use of broad-spectrum antibiotics for long periods, and also regular meetings with the infectious diseases team to review current infections, antibiotic use, and appropriateness of such use. These are a number of infection control measures that are seen. The first photo demonstrates the alcoholic hand wash that is pretty much available every 1 to 2 metres and also available at every bed space, and also the use of isolation rooms and contact precautions for some types of infections. So when we look at levels of infection control, we have 4 main levels, first being standard precautions, which escalates up to airborne precautions. Standard precautions apply to any healthcare worker and includes hand washing before and after patient contact, which may be with the alcoholic hand wash, in use of gowns, gloves and eye protection if exposure to bodily fluids is likely, the safe disposal of any contaminated equipment or linen, and cough etiquette. Contact precautions are the next level up and are often used with patients with MRSA, VRE, infectious diarrhoea, and infective or uncontained ulcers or wounds. This includes, in addition to standard precautions, isolation rooms and cohorting of patients with these infections, the use of gloves and gowns for entering rooms. These gloves and gowns are discarded prior to leaving the room and hands are washed again, and trying to use dedicated equipment for that patient. Droplet precautions apply to patients who have influenza or meningococcal or other such illnesses that are spread by droplets. In addition to the standard precautions, these patients are cared for in an isolated room. Staff caring for the patient should wear a mask within 1 to 3 metres of the patient, and if the patient is transported around the hospital, the patient should wear a mask. Airborne precautions are the highest level of precautions and are applied to patients who have very infectious diseases such as tuberculosis, smallpox and SARS. Again, in addition to standard precautions, these patients are nursed or cared for in an isolation room with negative pressure. There should be a HEPA filter, and healthcare workers are advised to wear an N95 mask. In addition, anyone with decreased immunity or at risk of these infections should avoid having contact with the patient, and the patient shouldn't be transported out of their room unless absolutely necessary. Nosocomial infections are very common and increase morbidity, mortality and cost. The common causes are those multi-resistant organisms, which are quite difficult to eradicate. It's everyone's responsibility to practice infection control. This includes hand washing before and after seeing every patient. There are a number of reasons that we want to improve our infection control practices and decrease the number of patients who are colonised with these resistant organisms. Isolation rooms are very difficult to manage patients in, and if we had less of these multi-resistant organism infections in the hospital and colonising patients, it would actually make care of the patients much easier. Improvement is always possible.